Hey, welcome to the podcast. I'm your host, Ankur Patel. And today with me, I have Alok Chaudhary, who's the Chief Data and AI Officer at VCU Health. Alok, welcome to the show.
Hey guys, thanks for having me.
To start off with, would love to hear a little bit more about your background and specifically how you got to the position that you're at today.
Sure. Well, I've been in healthcare for actually 20 plus years. I started actually as a programmer developer, a lot of hands-on work early in my career. I got into the leadership positions about 18 some years ago. Um, and I joined VCU Health, which is an academic medical center here in Richmond, Virginia, very recently, actually, just a couple of months ago. And I joined here as the inaugural Chief Data and AI Officer. So lots to do here and a lot of exciting work to do.
That's great. And then at VCU Health, what's the primary mission of the company?
Well, we are not just a healthcare company. We are an academic medical center as well. So when we talk about academic medical center, research takes a very important role, and it's one of our mission to bring the clinical research from lab to patient bedside. So this and that all is of course driven by data. So our role from data practitioner side of things, it becomes so critical, and something at this point in my career I like to be part of and enjoy. So yeah, I mean, it's being in an AMC, I feel, is another level of complexity from the data standpoint, but it is also very interesting role.
Would love to hear a little bit more about some of the data challenges that an organization of that size and scale faces. Because I think in healthcare, it's not only a regulated industry, but just given the sensitivity of that data, it's even more sensitive than perhaps basically in insurance, for example, or financial services more broadly. So curious, what does that data management process look like, and what makes it so particularly challenging today?
Yeah, I think that's a good question. We in healthcare, of course, the data takes different forms. Just looking at the data itself, I remember reading not too long ago that 70 to 80% of data in healthcare is unstructured data. So we work with a lot of unstructured content, a lot of unstructured data. And then, of course, patient data privacy, HIPAA regulation. We work in a highly regulated industry. So it's very important for us to make sure that we secure this data. Anyone who accesses this data, they need to access only from need to know basis. So data security, privacy, working with all forms of data types and formats. It just makes things fairly complex, but interesting at the same time. Now, we would love to get more into, I would like to talk about, some of the technology work that we do, to work with this type of data, and how we address some of these challenges. But I think that's the nature of our work. The EHRs and all of these different applications that we have, the type of data that we collect, bringing it all together. We don't necessarily have standards in place in healthcare. A lot of these applications create data, bringing it together, collating that, and making sure that we are able to report out from that data is not always very easy and straightforward. So a lot of those challenges to deal with as well.
Yeah, I think the particular nature of healthcare data, right, the unstructured and semi-structured documents, a lot of it is still fairly manual today, even with electronic health records. It's something that we commonly see as a major challenge in enterprise. And I think unless you can go and work off of that data well, so get it structured, formatted, stored in a format downstream that is usable by some of the newer technologies out there like generative AI, you miss a lot of the value that the newer software like AI in particular could deliver. So maybe let's talk a little bit about how that data comes in, so that life cycle, right? How does that data come in today? And what are you doing to help get that data in order for there to be more downstream value add from some of the newer technology that we're seeing in the market?
So from data lifecycle management standpoint, information lifecycle management standpoint, we um, we actually bring and I'll touch upon DLM first, because DLM, the way I look at it is a little more high level, which actually includes and encompasses ILM as well. So on the DLM side, we look at at that, let's say, table level. When we look at ILM, we start getting into the context itself. We start looking at down to the more granular data element level. We start thinking about what's the context of this information, how this information will be used by who. Is the it is it something which will make sense in a certain use case, and then we as we start bringing this data into, let's say, from the systems of records into the platform where we can do more analytics, AI type work. We want to actually bring all of this data together from multiple systems of records and start bringing or creating patient 360 type view. That's where we actually start applying some of the data governance principles and practices with from data cataloging to doing data profiling, working with our data
Yep.
stewards and data custodians to be able to work with this data, catalog this data, identify the gaps in the data, look at upstream where this data originated. Are there any challenges where that may be contributing to gaps in the data integrity issues. So we work with all of that. We and that's where we leverage a lot of the existing technologies in the cloud to help us with that. We define these type of roles working with our business stakeholders. They, of course, are domain experts as well, and they very quickly, as they see through these tools, some of these challenges, it becomes easier for them to act on as well. So yeah, these types of tools that we now see in the marketplace, cloud-based technologies, help us a great deal with
Yeah.
our work.
So let's talk a little bit about data lifecycle management, DLM as you refer to, and information lifecycle management, right? ILM. Could you maybe just for our audience define what it really means by DLM and ILM in the context of healthcare? I think that'll help contextualize at least what these processes are, and then we could delve a little bit deeper, which is where do these data, where does the data get stored? How does it get piped into the workflows that you have? But maybe just definitionally, if we start with DLM and ILM first.
Yeah, so I think if I have to think from the healthcare context, I feel like maybe a good example is when we, let's say, when a patient has a visit. So when patient has a visit, what we call visit or encounter, if we look at everything that we did, with that patient, I can view it as DLM because we are collecting every touch point that we have with the patient. We are collecting all of this information. So we look at that patient encounter holistically as data. So everything that we collected, as part of that patient visit. But then we start looking into, from ILM standpoint, all of these different data points that we actually collected. For instance, when we visit a clinic, we all know at some point of our lives we either have been patients or will be patients. So when we go to clinic, when we have a doctor visit, our vitals are taken. So all of those vitals become those specific discrete data points that I view as information that is getting stored now in these different databases. When we have to go through procedure, we got certain surgery done. That's a very specific procedure done by a very specific clinical clinician. These are the types of information. In our EHRs, we record problem list. That's a list of diagnosis codes, of all the known disease conditions that we may have as patients. Those are all the different data points that that becomes part of the information in our patient charts. So if I look at all of this, we are producing so much of it. Petabytes of information we hear about
Yeah.
every health system producing. All of this, is coming into our EHRs and other systems, billing systems, our lab information systems, our PAC systems, and so on. So we really, again, from the analytics and AI standpoint, work with this type of data, bringing it together, and be able to develop insights and produce insights for our clinicians.
Yeah. So where in that journey are you today? So I think part of it is, can you get that data piped into a way where it's more easily accessible, that you get either dashboarding capabilities or analytics, or you use generative AI as well for at least some of the retrieval exercises that are very, very commonplace, right? Or moving data out of documents in a key value pair output to go and plug into the workbenches as some of the teams might use for, let's say, billing purposes or claims management, things like that. For your business, when that data gets put into a downstream like database or data lake or EHR and other systems, what type of things have you seen that have delivered business value? So maybe if you could just tell a simple story or an example where that data lifecycle management has been additive to a business outcome downstream, that would really help contextualize that for our audience.
Sure. I think one of the things, and this is not really, I would say, specific to healthcare. I think this is something we all as data practitioners know, and we hear about. End of the day, it all comes down to right information at the right time for right people. So that paradigm I feel is probably so important in healthcare. Again, mainly because we are dealing with patient lives, human lives. So anything that we do from the data standpoint, we data lifecycle management, information lifecycle management. End of the day, our goal is how do we have the right information be presented to our clinicians at the point of care in the right format. So all our work actually is centered around that. We when we actually look at data quality challenges and issues, we look at if we are missing critical piece of information for a specific metric that is very key to certain workflow or a process. So we look at a lot of those things as an example. This type of work where it brings value. Of course, we deal with reports and dashboards. Most of these systems of records these days have all kinds of reports and dashboards and KPIs.
Mm-hmm.
When they don't, or when we are challenged with bringing data from multiple systems of records or external sources, even that's when we have to do a lot of the custom work in our data warehouses and data lake houses or data lakes. We then actually take this content from multiple sources, and then we create dashboards or analytic solutions or artifacts for end users. I think a great example I can provide is we 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 do look at in a lot of these systems of records, these reports are mostly operational, and
Mm-hmm.
that's something we need, what we call descriptive analytics. But as we start getting into more diagnostic analytics, predictive analytics,
Yep.
and prescriptive analytics, that's when we start looking at some of the solutions that we will have to create that we may not always have. So as an example, we work on, and so many examples come to mind, but we have challenges. Let's say, for instance, in systems I have worked at, and we have here as well, hospital acquired infection or hospital
Yep.
acquired condition. So something like that, for instance, our CLAPSI or COTI or SSI, we may have higher incidence. How do we make sure that we bring those numbers down? And that's where our analytics work come into play, where we actually are able to bring in the insights in front of our nurse managers or decision makers, where we bring that information at a very granular level because we have protocols, best practices set up as part of our workflows in EHRs. But we have to make sure that our clinicians are able to adhere to those protocols. And if they are not, the studies have suggested that we will have patient quality issues. So
Yep.
one of the things that we do is we make sure that this is the type of information which is captured, protocol has been adhered to. If not, that's the information we are able to bring to our nurse managers and decision makers, and they act on it. And we
Yeah.
actually have done these type of projects where they included some of the training for these protocols based upon the insights we provided in their onboarding process as well. And we actually saw over time some of the improvement in the scores through compliance actually with these protocols.
Let's talk a little bit maybe about some of the patient ingestion, right? So they come in to like a clinician, and this is more broadly within healthcare. A patient comes in, they're newer to that facility, maybe they have some prior history, maybe they fill out a couple of charts, maybe done manually, like on paper as opposed to digital. When you get this context in the system, is there do you have software that makes it easier for the clinician to understand prior history, maybe work through some patterns that they should really dig in on? Um, And if so, what does that look like? Because that's kind of when I think about like first interaction with from a clinician with a patient. How do you make sure that they have the appropriate context, particularly if that context is coming from prior charts or prior history from other providers, and now you have to basically assimilate all of that tapestry in order to make the clinician effective in the 15 minutes or so that they spend with the patient. So, what does that look like? What are some of the challenges? Have you seen examples where that's been really successful, where the clinician has gotten like software driven outputs to make them better at the diagnosis part?
Ankur, that's a very good question actually, because as you asked me that question, I was thinking about AI actually, because this is actually a perfect use case for AI to be that assistive technology to our clinicians. And I say that because you're right. We have this information, not always, but we have this information in patient charts, in EHRs. Um, in some instances, we have multiple EHRs in one health system. We may have other applications as well because images live in another system. We may have lab information system for radiology, cardiology. We may be using some other applications. So it's not very easy always for clinicians to be able to collate all this information and be prepared when they see the patient, and they know exactly in terms of patient history. And in EHRs we do have, and is supposed to be available, but that may not always be the case. So really, in terms of again that this use case and AI, what I feel, and I will say that this is one of the use cases that is being looked at. EHR vendors are looking at. There are some early solutions or models already being worked on, where these AI solutions actually look at all of this data and they can summarize that and present that summarization in a very readable and usable format to our clinician, so that they know exactly more about that patient, that
Hmm.
what's the problem list, what are the medications this patient is on, what
Yep.
what to expect when the patient present themselves to the clinician. So again, yeah, there are a lot of great such use cases for AI in healthcare currently. Again, but coming back to your question, all of this information should be available in our EHRs, Epic, Cerners, all scripts of the world, or I should say Veradigm, where we have this type of information that clinicians actually go through. So, but I think again, this is an area which is improving and evolving with technology's assistance.
So what prevents that from happening though? Is it that the software to go and provide that assistive capability to the clinician hasn't been developed yet? Or is it is it the quality of the data may be hard to go and make available in a digital format for some Gen AI or some AI based software to run? Because part of it is like you should expect to see more of that assistive capability, right? So that co-pilot experience you're seeing in a lot of enterprise. I think having that same sort of assistive technology with clinicians would be incredibly powerful, and I don't know if that's really happening. One area that we do see activity, and this is also from guests that we've had on the podcast, is you see transcription. So when a clinician sees a patient, you see the patient and the clinician conversation get transcribed, so it's available for future reference. And that way, the clinician can spend more time face to face with the patient without really taking notes in the same way that they had previously. So that's great. That is a great technology that's in practice today. But in terms of the co-pilot experience, analyzing some of the pre-existing history, I wonder like what are the big blockers to making that a reality across more of healthcare?
Sure, I think you hit upon one of the primary, I would say, use cases that, in fact, we are in the early stages. I will say starting a POC with that scribing technology, the
Yep.
ambient intelligence. Um, but actually, I won't say necessarily barriers that we have currently. I think it is more to do with again the fact that we are not working with or dealing with widgets. I mean, these are human lives that we are working with. So we have to be extra cautious about whatever we use from technology standpoint,
Hmm.
um, is truly reliable. This is something that we can rely 100% of the time. We just cannot leave anything to chance. We cannot
Yep.
expect an AI to play bias here or hallucinate. I don't want an AI model to hallucinate when the clinician is I'm the patient and they are I'm working with a clinician. So I think if we put ourselves as patients in those shoes, I think we will start appreciating the fact that even though these technologies are making probably more headway in some of the other industry verticals, in healthcare, we do have to be more deliberate about how and where we use it and be very cautious about it. And we are using it. I mean, we in the
Mhm.
I would say in the administrative areas, we are already using a lot of this. Coding is one area that comes to mind in the on the billing side. Um, Even actually on the from clinicians, as an assistive technology, we have another POC here at VCU Health where we would be piloting this on the in-basket messages that our clinicians receive,
Mhm.
how a response can be generated, that our clinicians can then review and then, it can then go out. So it is something that is 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 gaining ground in healthcare as well, even actually on the clinical workflow side. But again, we have to just make sure that this is something which is really reliable. Another area, the summarization of the text, the notes that I touched upon earlier. That's another area which is all of these type of smart tools are getting embedded within the EHR workflows. So yeah, it is coming along. We are seeing more and more adoption of these, but again, we just are being more careful and cautious about
Sure.
how and where we use it.
No, I think that makes sense. I think that in these very sensitive workflows, in the regulated spaces that we're in, where you're touching people's physical lives or financial lives, I don't think you could be um, cavalier, right? So I think part of it is you need AI that is explainable. So being able to explain why the AI came with a particular response or result, so you could trace that. I think just to even build trust, but you might even need it for the regulators and internal compliance teams. You need confidence scores, so you should have a good proxy of how confident is the AI in the response, because you need to start developing trust not only in the AI but in the confidence scores that are getting generated. So you could,
Exactly.
you could double check the one where there's high confidence, but since you've already double checked many before and you know that above a certain threshold it's extraordinarily confident and good and accurate, right? In the same ways that people would be, you'd want to be able to kind of have that proxy. And the confidence scores I think are great feature that classical traditional ML had. I think generative AI doesn't quite have out of the box, and that you have to engineer. And then you do want there to be like some sort of self-learning capability where the AI continues to get better, right, through repeated use. And so maybe initially it's a pilot. You're able to highlight things that are amiss, like basically not working super well, and that's used as feedback by either the engineering team or maybe it's a self-learning mechanism for the model to improve on. There are various ways to do this, but that has to get done in order for this to be reliable, for you to use it in production. But I do think that this is an incredible time to experiment, which is you
It
get to
is.
go and introduce technology in a sandboxed manner, see what the limits are, start really getting reps in. Because only if you experiment now is it possible to go and start paving the way for this to be usable in a production setting in a year or two from now.
No, I completely agree with you, Ankur. One of the things that I like to do, and that is something I plan to do here as well, is creating a lab type environment.
Hmm.
For where my team, I mean, on the cloud, it's so easy these days to really provision the compute, the storage, and for us to be able to really have that sandbox environment. So really, what one of the things that we want to do is in that environment, be able to, whether it's synthetic data or our own data, just making sure that we do in a very secure way, but be able to actually create these types of solutions, be able to do
Hmm.
POCs, prototyping, be able to share that with our end users that hey, look, this is something that can be done. This can, is this something that can help you? as opposed to just thinking and waiting that, hey, let this play out on its own. I don't think we can do that in healthcare either. Um,
Yeah, I mean, I think there's a risk in waiting too long, right? I think it's like you need to experiment in a controlled, as you said, lab environment or sandbox environment. But by experimenting, you ultimately do end up delivering better outcomes. You just need to make sure that it is viewed as like a beta capability. So I'll just give you an
yeah.
example. I think you could get incredible insights and analytics built on IoT data that's being collected on individuals, right, from different devices that they're wearing, like an Apple Watch or Ring or whatever it might be. And the critical thing is like there are some incredible insights you could deliver. Now you have to make sure that you're not prescriptive as a like a medical provider, like over indexing on that. But some of the use of that data could be really helpful to provide the patient that you have some really good awareness of things that they should monitor as they live their lives in between visits, right? And if you have access to that data, if you could securely kind of get that piped into the provider side, that could also be really valuable. Again, data that I don't think is being actively used in that way, but could be with a little bit of in some ways like experimentation, right? To figure out how to go and use that data to go and deliver better outcomes long term.
Exactly right. And when you mention the wearables, um, that's an actually area that we want to get more into in terms of getting that IOMT type data, be able to do analytics
Mhm.
with that, combine that data with clinical data that we see in EHR, find anomaly, find um,
Yep.
find those nuggets that we may not be able to, our clinicians we may not be able to, given we have so much data. um, and I think if we do not do that in a lab type environment, we we don't learn. We then
Yep.
will constantly be in that environment where we are working with these requests that are coming in, these incidents. We just do this ticket and keep working on, which is something we have to do, but we have to, I feel, get to the next level. And that next level is, how do we really leverage these technologies? Because we have been talking about digital, and we are digital. All health records are now, more than well over 90% now health systems have EHRs in place, and we are now sitting on all this digital information. We can do
Mhm.
reporting on it, we can do BI. That is
Yep.
something now we have been doing for years. Well, now we can use really some of these tools like AI to do actually even more and bring that intelligence actually into our workflows. So great opportunity.
I think EHR has been incredible, right? I think there's so much now digital data that's available. Now it's a question of what do you do with it? How do you make it easier? I mean, there are other applications that I'm very curious about and curious about what you've seen and what you are seeing there is, like prior authorization, right? Asking
Mhm.
your insurance provider, your insurance, like I guess the insurance carrier you have, to see if certain procedures that you need, you could get pre-authorization for or prior authorization for, and in order to see if it's covered and what and how much of it's covered and how much might be out of pocket. That process is still fairly broken, where you do have to get on the phone, you do have to call your provider calls the carrier and provider work together. That's like one way to do it, or you call on your carrier yourself, the insurance carrier, and you try to get some answers from them. That process feels like it could be updated quite a bit, which is like you have prior history of the patient, you have insurance policy, like at least the ID numbers and the credentials, and then it should just be querying the policy documents with the prior history of the patient, and then you have context of what the patient billed for in the past year or whatever it might be, to go and say how much is remaining on the deductible, how, is it in network, out of network, all these things that are really just complex to go figure out. And that should be something that's self-serve, where a patient can go and figure that out on their own. Um, and I'm curious, like, what makes that such a hard problem other than just like building the software to make that
I
happen?
think being a technologist myself for so many years and being in healthcare for almost 2 decades, I feel, and I will say this, that technology is not the problem always. It's it's your people and process side of things, um,
Mhm.
and those are harder to solve than technology. So we do have challenges with technology. We have interoperability challenges. HL7 is still how we exchange the data, though we are adopting FHIR more and more. I want to also mention that Health and Human Services, OMC, they've been doing great job. After Cures Act, some of the standards that they are bringing in, USCDI has done phenomenal work on some of these standards and FHIR APIs that we can use, and some of this is mandated now as well for both actually payers and providers, and actually on a broader scale for all healthcare stakeholders. So even health IT vendors will have to comply with a lot of regulations that are coming up. So, prior auth, just as an example, yeah, it has always been a challenge. And again, it is, I would say, more to do not necessarily on the technology side, how the data is or information is shared, but it is more on really the requirement part of it. Though um, there are a lot of steps that are being taken both on the provider and payer side. We can say ONC is also mandating some of this, but even beyond that, what we are finding is in our EHRs, we now have better ways where the information can be sent directly to payer,
Mm-hmm.
and it goes in HL7 type format. They are part of the same, let's say, Epic platform where they get this information, they can act on it, and they can respond. And then from the mandate side of things, the expectation is that within 48 or 72 hours, they have to respond. So I think in combination, if you look at the technology, the regulation, we are getting to a place where things are becoming better, but there is still a lot more to be done. But I will say our prior auth is one of the areas where some of this closer integration between our applications and systems and the data exchange is making things better. But it is happening between one health system and one payer. So it is incremental, but we are slowly getting there.
Yep, yep, that makes sense. I think that makes a lot of sense. What about the reimbursement and some of the payouts and the billing aspects of things, which is you had a procedure done, you want to make sure that the proper billing happens, right? So the right parties get paid the right amounts, and some of it's even tracking like the nurses and the traveling nurses and some of the costs related to that, just to make sure that the hospital administration has a good handle on the invoices that they have to go in and work through. Um, what about those like back office workflows and middle office workflows where it's about payments and billing, and how much of that has been enabled through really great new software versus it's still being done through like BPOs and more manual activity?
Yeah, I will say, Ankur, I'm really not really an expert in that area, but I can tell you that um, it is getting better. Now, there are still a lot of challenges with reimbursement in general, and I won't get into some of the challenges that we see and I've experienced working with some of the teams internally with our health systems, where the payments are getting denied for one reason or the other.
Hmm.
So we still see a lot of that. On the provider side, we do actually have um, we do incur a lot of um, avoidable cost because of the reimbursement getting denied, again for one
Yep.
reason or the other. Usually it is that coding is incomplete, incorrect, so we have to go back, fix it, and then
Yep.
submit those charges. So a lot of that back and forth does occur. um, Actually, even with that, some of these, like I mentioned, prior auth, the idea is that some of this will make the overall experience better because the payer would have some of this information ahead of time, like through prior auth, and there is actually, we are doing integration with different payers directly, where they will actually have more clinical data they will get as well immediately after the patient visit. So,
Mhm.
for us to be able to fax it and, have that paper-based processes, we are now replacing a lot of that. If it's not already replaced, because mostly it should be replaced.
Mhm.
But we have now through EHRs those capabilities where we actually are creating these single connection points, if I can call it that, to these specific pairs we work with. And we actually not only the information related to prior auth, but the clinical note or clinical summaries, what was done on the patient, we are sending that information as well. So it's making the overall process better. I will say that a lot of this we are still in the process of working and getting this in place. One of the data points that we want to actually be able to see once we have some experience and have spent considerable amount of time with this type of integration is to be able to see that, hey, did our denial rate go down or not?
Yeah,
Because
sure.
that's the end of the day,
Sure.
that's the expectation, that our AR days need to improve, our denial rate need to go down. So we are not there yet. But that is one of the areas that we want to actually pay close attention to and do more analytics with.
I think that's right. I think that this whole process of going through that reimbursement, flagging things that are anomalous or like fraud, you definitely want to do. But at the same time, you don't want clerical errors to kind of be the stopgap, and then have to kind of redo things, right? That's just introducing more administrative work and frustration. And so I think part of it is, can you introduce software to go and make that evaluation process more automated, so that the smaller clerical errors aren't the reason why some of these things aren't getting to the final outcome that they need to, right? And I think there's a huge amount of opportunity there. Again, I think what's happening, I think, in the world of AI is that you're trying to take on tasks that would have been BPO like activities that would have required people to go and examine, review, and work through, and you're able to go and create some level of automation, because you have new technology that can reason and understand in ways that people can. And I think that is going to introduce a world where people aren't going to be doing as much clerical administrative work, right? And I
Yeah.
do think it's in some ways similar to like doing long form math on paper. It's like, that was how math was done before calculators, but once calculators and spreadsheets and other tools got introduced, you had just phenomenal ways to go and do long form math, right? So you didn't need to do it on paper. It's that level of improvement in how work gets done. And it starts small because, like, you might not trust, is a spreadsheet calculating the numbers correctly, or is a calculator, is that calculating the number correctly? So you have to basically check with your long form notation and see if the math on paper holds in the same way that it did electronically. But then after a while, once there's like organizational trust, once there's industry trust around the use of some of these technologies, then you just like by default use some of the technology, and you forget in some ways the older ways of doing things. And I think that will play out over the next 5 to 10 years. Just an incredible time to be building right now, and identifying where the use cases really make sense today, in terms of moving the needle for different business outcomes out there.
Yeah, I think I feel that AI is such a huge opportunity as an assistive technology in a lot of these different areas. Just what we are talking about coding. Another area where we actually have such a great potential is where it's not necessarily if there is, our charge capture, we have something deficient, which is why the claim gets denied, for instance. In lot of instances, what also happens is that in the charge capture process, we actually miss billing for something that we should have billed. Um,
Hmm.
and a lot of times, what happens is that our coders, they have such an important role to play, and it's not a very easy task what they have to do, because they are the ones who have to make sure that we are capturing the charges correctly. It's all coded, the documentation is complete before the charge drops. um,
Hmm.
the we have the clinicians actually have these notes, so a lot of information is sitting in these notes. But it doesn't necessarily come into a discrete charge capture process where we can say, when the charge drops, that it is actually for, this is the primary diagnosis, or this is the secondary diagnosis, and this is exactly what we need to be paid for. So we have a lot of those missed opportunities as well. And this is where, again, AI can play such a big role because it can actually be able to go through that, the unstructured content and be able to bring out some of the information discreetly, which will actually help from the billing standpoint for the procedures or clinical services that we provided that we would
Mhm.
not have built otherwise. So again, great opportunities where we are seeing some of the vendors in this space are already looking into bringing some of these AI opportunities into their tools, and we look to actually using those and see really how it helps us.
How about the adoption from some of the hyperscalers in terms of the move to cloud-based infrastructure like on Azure or GCP or AWS, as well as the use of, let's say, large language models? What's been the appetite to use either closed source model players and some of the activity here, or if not closed, then open source models? I'm curious what the temperature is within the broader space today.
Yeah, I think I can speak to from my experience. Um, we have not really delved much into that yet. Now, having said that, all of these cloud-based platforms, what I call modern data platforms or modern data architectures, support all cloud native technologies. So we want to make sure, and we are making sure that we will have access to all of these different foundation models that we can work with.
Yeah.
As part of the lab environment that I alluded to earlier. Um, so we do have some of these closed source foundation models that actually have token based pricing as opposed to some
Yep.
of these open source. So we are not there yet, but that is something that we plan to look into. We want to make sure that we will have access to these. We will have access to all the right libraries that our data scientists can work on. We can we can work on and develop our own. Nothing really. There is no point in developing anything from scratch, but be it prompt engineering or RAG,
Yep.
some of that we can use, and that's where our experts will come in and be able to work on that. But we are just making sure that we have that cloud based right environment in place for us to get into this space really.
No, I love that. I think that's right. I think you set that up so that your internal teams can use their domain expertise, and experiment with some of the newer native cloud native technologies, right, including the models. And I think I think as we said earlier, I think experimentation is really pivotal. The more you experiment, the more learnings there are, and it's like one small step towards getting more value in production, right? So you have to go through the motion. I think a lot of questions I get asked in like the past year has been the enterprises are doing a lot of POCs. It's like fewer things are getting into production, at least yet, right? And some are, by the way. I mean, it's not that they're not, but there are a lot of POCs underway in the industry more broadly, and I think people view that as like as a cause of concern. But that's where things need to start. You need to be able
Exactly.
to experiment, design, learn. These are necessary steps. Just because it takes time to get to production doesn't mean these are the wrong experiments to be running right now. These are absolutely the right things to be doing at this juncture to make it easier to go and build that, like basically that muscle tissue, for the institution to be able to go get things into production in the next year or two.
Yep, no, completely agree, and that's exactly what how I view things as well. Sure, we will have more POCs, but I mean, this is such a transformative technology that I would say once in generational type technology, and it
Hmm.
is so important for us to do our diligence. It is important for us to learn, and then be able to find value from it. And once
Yeah.
we do, and we are confident, then working with our stakeholders, move it into production. So sure,
That's right.
we won't have too many of these going into production currently, but over time, as we become better, as we learn more, we will find more and more of this actually solutions created with these technologies going into production. But we don't want to rush it. We want to make sure that this
Yeah.
is done right, and this learning is helping us. We are learning as we go, and this is also new. I mean, I'm learning every day. I'm learning. I'm constantly actually going and reading articles. Um, I was in a conference just very recently where we had everything was AI. I mean, in any data conferences you go to these days, AI is front and center. And
Yep.
all the things that when I talk to my peers, is that we all are in same boat. We are all
Yeah.
working through, even defining what is responsible AI. Um, and do we have any policies and guardrails in place where we are at? So most of us are in very early stages, and we are. The important thing is that we do recognize that it's early. We do recognize it's a great technology. We do know that it has its own caveats, and it's very important for us to really learn and be able to see what are those caveats and be able to cover our bases before
Hmm.
we say that, yeah, this is all ready to go into production. So I think again, it's just a great learning process for everyone involved.
I agree, Alok. Well, it's exciting to see where things will go. We'll follow you closely, I'm sure, with the new role, with the lab that you're setting up, and yeah, excited to see how things turn out over the next year or so. So I'm sure we'll be in touch on that. But it's been a pleasure having you on the show. Thanks for the time, and for our audience, if they want to learn more about you, where could they find more about you or VCU Health next?
Well, I think the best way to reach me is through my LinkedIn profile. So that's probably the best way to hit me up, and I'll be happy to connect with others. And any questions or thoughts, viewers and listeners have related to data analytics, AI in healthcare, I'm more than happy to connect.
Amazing. So we'll include that in the show notes. Thanks for being on the show. Really appreciate the time today.
Thank you. Good talking to you.